Hey everyone, welcome back to another PS Platypus lecture. I know it's been a while and I hope that you're doing well. Today we're going to be looking at the central nervous system in a little bit of a closer detail. So far we've essentially looked at all the tissue that is important in the central nervous system. So mainly the brain as well as a little bit about the spinal cord. But today we're going to be looking at what actually keeps all of that tissue alive, which is going to be essentially the blood supply, which is a very, very important topic to understand, especially when we get to the clinical correlates like bleeding and stroke. There's also this unique system in the CNS known as the ventricular system, which is also quite important, mainly for anatomy, but there also are some clinical correlates there. As always, my notes are linked in the comments underneath these slides. So if you do have any further questions or concerns, please feel free to look there for some more detail. And also, as always, feel free to message me if you have any more specific concerns and things that are not actually mentioned in any of those other resources. So without any further ado, let's begin on this lecture. So the journey of the arterial supply begins with what is known as the circle of Willis. But I think that when this is thrown at you as a diagram, it can feel really daunting to understand what the whole point of the circle of Willis is. And more importantly, where does it come from, right? Like what is actually supplying it? And I think to make things a little bit easier for us as we go through these lectures, let's actually just ignore all of the labels on this diagram and instead focus on the shape as well as the origin of this actual supply. So the way that I like to think about this and the way that I learned this in second year is when you look at the shape, you'll notice that there are two major arteries that actually supply the whole blood system. That's going to be this major artery up here, so on both sides, and you've got these two major arteries down here. And so anatomists like to make this a little bit easier for us to understand by cutting this system through this plane here, which is essentially halfway through the posterior communicating artery. If we cut through there, we end up with a top section as well as a bottom section. Or more accurately, if you look at it on a specimen, that's going to be an anterior section and a posterior section. A quick word with what I meant by in situ, or if you look at these things in a human body, that actually gives you a bit of a better idea of how this is actually going to be positioned. Because in all diagrams, it looks flat, but actually, if you look on a specimen, the system actually goes up. So you've got vertebral arteries, you've got carotid arteries, they go up through the midbrain. But then once it gets up to the brain, it has to kind of flatten out like this. So it actually curves instead of just staying flat the whole time. So that's what I mean by, getting a bit of a better picture of what this looks like. But apart from that, if you've seen it in a real specimen or some models, that should give you a really good idea of what I'm talking about. Let's focus back on the branches though. So if we make that cut, what we end up with is two major circulations that contribute to the circle of Willis. The first one is going to be the anterior circulation, which is provided through the internal carotid artery. Now, the diagram that I've included there is just to show you that the internal carotid artery doesn't just come out of nowhere. And we know from our studies of the cardiovascular system that the internal carotid arteries start from a bifurcation of the major branches that come out of the heart and the aorta. But once we get to the internal carotid, it continues to go up towards the brain and it travels through the petrous part of the temporal bone. Before it does a couple of maneuvers here and there, it kind of goes in and out, before finally reaching its final position within the brain parenchyma itself. Now, I know I've said in and out as if it's not a big deal, but obviously anatomists have actually kind of structured this into like C1, C2, C3, C4, C5 segments. We don't need to know any of this detail, but I think it's important to know that the internal carotid artery actually has a very complicated pathway. So once it goes past the bone, so the temporal bone, it actually travels through the cavernous sinus, which is a venous sinus we will cover in a few minutes, before it then ends up branching off into those major anterior circulation branches. We also have this bottom circulation here, which is going to be the vertebral arteries. This one's a little bit easier because we've gone through this in a bit of detail in our spinal lectures, but we haven't actually covered what happens to the vertebral arteries once it's supplied the spinal cord. So it travels up through the cervical vertebrae, everything from C6 up to C1. It does a few maneuvers here and there as well before it enters through the foramen magnum into the brain tissue. So we've got these two major players that, well, like in the end, they actually branch off into many, many, many major players. So this is just going to give you a good idea of where everything starts. But when we're actually discussing branches, we know that the anterior circulation gives off three major branches. We've got the anterior cerebral artery. So again, if I use my pointer, it doesn't really help that it's red and the same color as the vessels, but I'll try my best. You've got the internal carotids, they go off to like this. They start here, right? Internal carotids start medially. They work their way outwards. The first branch they give off is going to be this anterior cerebral artery up there. So it branches off, gives anterior cerebral artery. And you'll notice that these two anterior cerebral arteries on both sides, they're going to connect in the middle through the anterior communicating artery. And these communicating arteries are just very special arteries that ensure that you have some form of collateral, just in case one side gets stroked out, you have the other side being able to supply a similar volume of blood. That's the anterior communicating artery. And if we continue following the internal carotid as it keeps going, it continues as the middle cerebral artery out here. So that's the anterior circulation. It's actually very straightforward. And I've obviously kind of missed out on a couple of these smaller arteries like the ophthalmic artery and this weird artery over here, but those are not really going to give us any pathologies that we are interested in. So we're just going to be focusing on those three major high caliber branches. If you look at this posterior circulation from the vertebral arteries in a bit more detail, those actually give off quite a few really important branches. So you end up with, yeah, I've got a lot of dot points, but I'll work through them in systematic order. So we continue up. It gives rise firstly to the anterior spinal artery, which I won't cover right now because that is mainly for the vertebral or spinal circulation. If we continue following it to inside the brain tissue, the first branch it gives off is the AICA, which is the anterior inferior cerebellar artery. And from the anterior inferior cerebellar artery, you also have this really small branch called the labyrinthine artery, which is going to supply the inner ear. So once that's done, we continue moving up. Notice that it has combined. So both sides of the vertebral arteries have combined to form this really big, kind of thick, high caliber artery called the basilar artery. And that travels up the midbrain, up the pons, and it gives off pontine branches because it's supplying the pons. Once it's supplied the pons, it then gives off another cerebellar branch called the superior cerebellar artery. And then it continues going upwards before it bifurcates again into posterior cerebral arteries. So I think as a broad picture overview, you can see that you've got some branches that go to the cerebrum or the brain, and then you've got some branches that go to the cerebellum, and you've also got a couple of branches that go to other aspects of the CNS like the eyes as well as the ears. But the main ones are the cerebrum and the cerebellum. And then finally, you get a connection between those two circulations, right? Otherwise, you wouldn't be able to form this nice circle of Willis. So they connect together, they form the circle of Willis. And if anyone asks you what the borders of the circle of Willis are, now it should be very easy to know. So on the anterior side, you have your anterior cerebral arteries on both sides. You also have that anterior communicating artery in the middle. Those form the anterior part of the circle. And then the lateral and posterior sides of the circle, you have the internal carotid, bits of the middle cerebral artery, as well as these long posterior communicating arteries that form the circle. Okay, so that's how you get the circle of Willis. But as one of our tutors told us, the brain supply is not just the circle of Willis. The circle of Willis is just the connection between the anterior and posterior. And really, the more interesting stuff happens within those circulations rather than in the circle of Willis. It's important to understand as well that the circle of Willis, the reason why it is a circle, I guess, is not only for it having collateral blood supplies on the left and the right hand side, but it also has to go around a major structure here. And if anyone knows this, extra points to you because it's going to be the pituitary gland as well as the cavernous sinus, which we will go through in a few slides' time. So that should give you a very good sort of broad overview of why we get a circle of Willis and what the significance of that is. But now let's get into the actual vascular territories. So each of these major branches that supply the cerebrum, which is going to be the anterior, middle, and posterior cerebral arteries, let's actually cover what they supply and what the significance would be if they were to be, for some reason, stroked out or damaged. Now, on the right-hand side, I've got these diagrams here that show cross-sections across the lateral side of the brain as well as the medial side of the brain. And I've also got this over here, which should be familiar from our physiology lectures, which are the motor and sensory sort of homunculus, or the topographical mapping of each of those structures, right? The motor and sensory aspects. You'll notice that just to make things easier for us when we go through the strokes is that you can imagine the homunculus as being a person who is lying down on the brain with their legs sort of hanging off the side. And that'll really help you to be able to figure out which parts of the body are going to be affected in terms of sensation and movement. But I'm going ahead of myself. That's going to be in a few slides' time when we cover strokes. So with the anterior cerebral artery, that supplies the anteromedial cortex. You can see that in the yellow region here. On the lateral side, it looks very small, right? Just the anterior bits. But if you look on the medial brain, you'll see it supplies pretty much all of the medial brain, okay? So that's going to be, if we correlate that to lobes, that's going to be the frontal lobe, more the medial aspect of the frontal lobe, and then most of the parietal lobe, as well as sort of the inner aspects, right? I haven't covered like the corpus callosum and stuff like that because that's really not that important for pathology. The main thing to understand here is that it supplies the superior medial gyrus, which means that it's going to be impacting on the motor and sensory functions within the lower limbs. And again, that really makes sense because if I'm stroking out this medial aspect of the brain, that's where the lower limbs are hanging off in this homunculus man. So it makes sense now why you would have supply to those lower limbs rather than to the upper limbs. For each of these branches, you also have very deep branches known as lenticular striate arteries. This is more for completion's sake rather than what you need to know, but it's important to understand that these deeper branches are affected when you have proximal occlusions of these particular arteries. So for the purposes of strokes, we're just talking about pure ACA strokes, but say you had a very proximal infarct of the ACA artery, you would not only damage the lobes, you would also damage the deeper branches, which in the ACA's case supplies the head of the caudate nucleus, as well as the anterior limb of the internal capsule. This internal capsule is going to come up time and time again. You won't really get like a formal overview of the internal capsule, I don't think, but it's a really important structure because it's prone to things like capsular strokes and stuff like that, which can affect a lot of function in one side of the body. But anyways, we're focusing more on the cortex. When we get to the MCA, we have a similar story. In this case, though, it's going to supply mainly the lateral cortex. So this really major distribution on the lateral side of the brain. And you can see it covers three lobes, right? It covers the frontal lobe, the parietal lobe, as well as bits of the temporal lobe. And the main thing that's important to understand here is that it is going to be supplying the lateral side of the same gyruses we were talking about. So that's going to be the motor and sensory function again. But this time, because it's lateral, you can see that it covers the upper limb as well as the face. Same here, right? Upper limb on the motor side and then face on the motor side as well. So that's why in this case, instead of lower limbs, it's going to be a little bit more caudal, right? It's going to be the face and the upper limbs. Plus blood supply to the Broca's and Wernicke's speech areas, which are located within the parietal lobe as well as the temporal lobe, respectively. It also has deeper branches. These are the lateral lenticular striate branches. These supply the lateral putamen, as well as the anterior aspects and the genu of the internal capsule. The posterior cerebral artery is essentially just the remainder of the cerebrum. It chiefly is going to supply the posterior aspect, which is going to be the occipital lobe. And it also gives off posterior choroidal branches, which supply the choroidal plexus. And the choroidal plexus will become more relevant when we do the ventricular system. Essentially, just to give you an introduction, these are going to be the arteries that supply the ventricles and therefore kind of keep those tissues alive. It also has deeper branches here that supply the midbrain, thalamus, hippocampus, amongst other things that I probably haven't included. But again, not so important to remember as opposed to the fact that it supplies the occipital lobe. And so you can imagine if you have a stroke in the PCA, you might expect some ocular problems and some vision issues. And then finally, you've got the anterior choroidal artery circulation. So remember, posterior choroidal comes off the PCA. Anterior choroidal is actually a separate thing. It's the terminal branch of the ICA. So the ICA has given off the anterior cerebral artery. It's given off the middle cerebral artery. Once it continues down and down and down, becomes smaller and smaller, it finally ends up in these terminal branches that wrap around those lateral ventricles, which we'll discuss in a few minutes. And then it contributes towards the anterior parts of the choroidal plexus. So now you've got the posterior choroidal plexus supplied, anterior choroidal plexus supplied. The choroidal plexus is nice and healthy. And it also has deeper branches which actually supply the remainder of the internal capsule that we haven't discussed. So the anterior bits are already supplied by the ACA and MCA. The anterior choroidal arteries supply the posterior aspects. So I know it's a little bit confusing, but if I was to ask you to consider which ones you need to remember, it would be all of these arteries, but not the deeper branches, because those won't really be the things you are concerned about in more distal infarcts, which we are more concerned about here. Okay, and just for completion's sake as well, I want to cover the other branches we discussed in the circle of Willis, which are the cerebellar branches that supply the cerebellum. And we've gone through the physiology of the cerebellum in quite a lot of detail. So you should be familiar with potentially what impacts these are going to have on things like balance and ocular function and things like that, and nystagmus, dysdiadokinesia, all those weird and wonderful things. But just for the anatomy portion of it, it's really easy because all these arteries are named exactly in terms of what territories they supply. So very, very easy. So you got the superior cerebellar artery, which supplies the superolateral hemisphere, and it's mainly going to supply the superior peduncles. Hopefully you've covered the peduncles in quite a bit of detail already. And remember, you've got superior, middle, and inferior. So that's really important to understand. The anterior inferior cerebellar artery is going to supply the anterior inferior cerebellum. Very easy. The lower lateral pons as well, because the pons is just anterior to this, and the middle peduncle. And finally, the posterior inferior cerebellar artery supplies the inferior cerebellum, the medulla, the lower vermis, and of course, the remaining peduncle, the inferior peduncle. That's really important. The fact that I told you about being able to look at a cadaver, or at least to be able to have a 3D model of this somewhere to relate to, is because you can see how the basilar artery supplies a huge portion of the pons because it gives off our pontine branches. The main reason I bring this up is because remember how I told you it goes, all of these branches that start off at the bottom, they'll go up first like this vertically. And so that explains why you get this basilar artery kind of wrapping around like that, gives off the pontine branches on either side, and then it continues up. Once it gets to the brain tissue, it then becomes more horizontal, and that's why you have the circle of Willis near the pituitary gland. So again, that just really helps to consolidate the anatomy of it all. And finally, we don't want to forget about the other branches that go kind of never enter the brain at all. They just go down into the spinal branches. So the vertebral branches here. You've got the anterior spinal artery. You've only got one of those. Travels down the anterior median fissure, and it branches off into sulcal arteries, which are going to supply the spinal cord. You've also got two posterior spinal arteries. These don't actually come off the vertebral artery per se. They actually come off a little bit more proximally, but it's not really important to understand their origin too much. At the end of the day, they anastomose together within the pia mater, and they also supply the posterior aspects of the spine cord. Below the cervical region, though, you can imagine all this is happening really high up. Below the cervical region, you need to have a few more arteries to be able to provide some anastomosis, just in case something proximally happens that strokes out those cervical branches. You want to make sure that there is some branches more distally that will be able to reinstate some of that blood supply. So the major ones to think about are going to be the segmental medullary arteries. You've got anterior and posterior. The major one that everyone fusses about is the artery of Adamkiewicz. I believe that's how it's pronounced. That's going to reinforce the inferior 2/3 of the spinal cord. So not really the superior aspect, because that's all covered. It's more the bottom 2/3. And you've got the radicular arteries that supply the nerve roots themselves, because they need to be vascularized as well. So here's a diagram that kind of goes into that in a bit more detail than you need to know. But if you're going to remember one thing, is just to, like, if this comes up in a question, right, the artery of Adamkiewicz, you know kind of what it's talking about. It's the inferior 2/3 of the spinal cord. Okay, now before I go into venous drainage, I just want to show you a 3D diagram of the arterial supply, just to be able to kind of go into a bit more detail about what sort of things you need to know when it comes to the way that it travels up the spinal cord. All right, so here we've got a 3D model of the brain with the arteries actually being displayed. Now this software, by the way, is free available on the Monash library resources. So I recommend using it if you don't want to pay any money for, you know, those app store things. But I think this is still a really good diagram, or a really good program to be able to show this in some 3D detail. So what I was trying to get at before when I was talking about the orientation is the fact that if you kind of focus on the origin of these major arteries, so you can first see this really high caliber internal carotid artery on both sides. And then you can also see the vertebral arteries coming up as well. So you can see vertebral artery coming up. The vertebral arteries combine to form the basilar artery, which is on the brainstem, and it gives off these pontine branches. And then if you kind of focus more on the inferior aspect, I don't know why it's sort of looped it around, but you can sort of see, wait, let me get a better image of this. So we've got that, there we go. So we've got the inferior surface. You can see what I meant by the circle of Willis now. So this whole thing here is the circle of Willis. You've got this connection between the posterior circulation, right, that comes through the basilar artery and comes through the vertebral artery. And then you've got the connection with the anterior circulation, which is the internal carotid artery, gives off the middle cerebral. It also gives off the anterior cerebral. You've got the connection in the middle, which is the communicating artery. You've also got the posterior communicating artery that combines those anterior and posterior circulations. And of course, this whole circle is going to be around the pituitary gland, hence why it is in a circle shape. So hopefully that makes a little bit of sense. And just to kind of illustrate this further, you can see how once it goes into the brain, everything is covered, but you can see how it gives off so many branches. So like middle cerebral artery, we know is going to supply a lot of this lateral aspect of the cortex. You can see more medially, if I was to focus on these branches, they're actually the anterior cerebral artery. And then if we focus more on the back, you can see that these are going to be the posterior cerebral arteries, which give off branches to mainly the occipital lobe. So now hopefully this makes a little bit more sense, and we'll go back to the slides to have a look at the venous circulation. Okay, let's have a look at the venous drainage. So in general, when we're looking at venous drainage in the CNS, they are composed of dural venous sinuses, and plural because most of these are going to be paired on either side, right, on left and right hand side. The responsibility of these is to drain the CNS, the brain, the scalp and the face into the internal jugular veins on either side, and then eventually drain back into the heart. So these are going to be, remember, between the periosteal and the meningeal layers of the dura, which are nice and taut layers to keep the veins from collapsing, because we want to ensure that we get proper drainage of the brain tissue in order to avoid any congestion. So if you look at this nice diagram here that has everything labeled, the main things to just take away is not so much all the names of every single venous sinus, but it's more about the pathway that they take before they enter the IJV. So you've got this really major, like massive dural sinus, which is going to be the superior sagittal sinus that travels sort of upwards here. It travels through the sagittal, the line that separates both of the cerebrum. So that goes down here. And you've also got it joining up with the straight sinus, which is draining some of these more internal things here. It also drains this really interesting structure called the cavernous sinus, which we'll cover in a second. But they all sort of drain into this straight sinus. They join up into this confluence of sinuses, which is just a dilation because of all this drainage coming in. You've also got it draining the occipital sinus from the back. All of this venous drainage goes into the transverse sinuses, which loops around, forms the sigmoid sinus, which then eventually drains down into the IJV. So as long as you sort of have an understanding of the general overview of where the flow goes, that's the main thing. You don't need to be able to name every single one of these sinuses, especially the ones that are very much deeper here, right? That's not really that important to know. The main important sinus that is the most important to know is going to be the cavernous sinus because of the fact that it's linked to a lot of pathologies. So it's on either side of the sella turcica, which is in the sphenoid bone that houses the pituitary gland. And the reason why it's so important is because remember that the pituitary gland, like any gland, can be enlarged, right? If it's overactive, sometimes if it has adenomas or masses on it, then it can compress things around it. And because of the fact that the pituitary gland is so intimately linked to this cavernous sinus, not only will you have obstruction of the venous drainage, you actually have so many things traveling through the sinus that those can also be damaged. So if we focus on it anatomically, you can see on the lateral walls, you have a lot of cranial nerves traveling through, and the order from top to bottom is cranial nerve 3, 4, and 2 of the branches of cranial nerve 5, which is V1 and V2. And they're all going to be traveling sort of inferiorly as they continue past. So you can imagine if we have a big enough dilation of the pituitary gland, it's going to hit all of those nerves. And specifically, you can see cranial nerve 3 and 4 being mentioned. Those are going to impact quite a bit on your ocular function, oculomotor function. Also, just within the cavernous sinus, so not so much outside on the walls, but really within the tissue of the cavernous sinus, you have the internal carotid artery. We mentioned how it sort of warps around and goes through. This is one of the places that it goes quite a bit. You can sort of see that it is here, and then it also kind of peaks out from up there. And the reason why is because it goes in and then comes back out. It's really weird, but I would suggest having a look at what that actually looks like on a cadaver. But you essentially have it going in, so you can get obstruction of the internal carotid artery, which is not good. And you also have cranial nerve number 6 going through as well. So 3, 4, and 6, right? All of the cranial nerves that are responsible for moving muscles in the eyes. So you can really have quite a bit of impact on eye movements, which is very important. Not only that, but above, you also have the optic chiasm, um, which is another cranial nerve 2, that is responsible for vision, right? So not only can you not move your eyes as good, you also will have impaired vision. And the diagram over here just shows you that kind of depends on how the pituitary expands. If it expands like this, then it's going to go more up to the optic chiasm. If it expands outwards like that, then it's going to go to those lateral walls and hit all those cranial nerves that we're worried about. Both of them are going to be connected in the midline by the intercavernous sinuses. They're not just separate things on either side. They are connected. And it mainly drains the ophthalmic veins amongst, a lot of these really minor veins that we've ignored here. And it's really important to note clinically that the superior ophthalmic branch or the superior ophthalmic vein anastomoses with the facial vein. Why is that important? Well, we know the facial vein is one of those extracranial branches. So it's outside of the skull. If you have a connection between the outside of the skull through the face and the inside of the skull, which is near the brain and the pituitary and everything like that, what can happen is if you have some sort of trauma to the face or within the sinuses or something like that, that is close to the facial vein, and if you say have bacteria or you have a thrombosis or you have pathogens entering, that's a very easy way for them to go from outside to traveling straight inside into the brain tissue and causing a lot of damage. So there's this zone called the danger zone or the danger triangle that you need to be wary about. But it's not really covered in this slide deck. If you just want to have a look at where that triangle lies, it's really important. Essentially, that triangle is going to be supplied by the facial vein or drained by the facial vein. And so, directly linking into the internal or the intracranial region, which is not good. It empties into the petrosal veins, and then eventually those will empty into the internal jugular as we would expect. Now, before I go into the ventricular system, I just want to go over the 3D model again of the venous drainage. So I will just go there now. So with this one, I've kind of removed the brain tissue because I think that's more of a distraction than with the arterial supply. If you just have a look at the way this is arranged, obviously it's very, very complicated and you don't need to know every single branch. But I think you can see here, if we zoom out just a little bit, you can see we've got this really massive superior sagittal sinus that starts up on the superior aspect of the brain. And you can also see how at the very end it joins up into this confluence here, which I don't think is actually labeled, but you can see a dilation, which is the confluence of sinuses. Maybe it is there, maybe not. It also drains this transverse, or it goes into the transverse sinus. Transverse sinus then enters into the sigmoid sinus, which goes down. So sigmoid sinus goes down into the internal jugular vein. So eventually all this drainage is through the internal jugular and then down into the heart. And then if you kind of look more closely here, whoops, if we zoom in like that, you can see how we've got our cavernous sinus. You can see here this cavernous sinus. In fact, I think this diagram is not as detailed as the one that we had on the diagram. So it just looks like a big blob, but it actually has quite a bit of stuff going through it. So if you want to add in some of the nerves and some of the internal carotid as well, actually, I might add the internal carotid. That might be a good one. Let's do, oh, that's probably made it too confusing actually. Internal carotid, there we go. So you can sort of see how the internal carotid there travels through the sinus. Again, it just looks like it's coming out, but you can see internal carotid goes in, does some stuff inside, warps around, and then it travels back up, and then it continues into its anterior cerebral, middle cerebral, everything like that. But it's not as simple as it looks, right? All this is so intimately connected, which is why when you have a pathology within the cavernous sinus, it has so much impact on nervous structures as well as arterial structures. So that's really important to remember. But let's go back to the ventricular system and end off this particular lecture. All right, last but not least, ventricular system. This is again a very important anatomical concept, but I think when it comes to clinical pathology, it's not really something you come across too much yet. The ventricular system is a system that is unique to the CNS because it's what's responsible for not only producing CSF, but also draining CSF from the CNS. Now, the CSF is important for a lot of reasons. It contains nutrients. It also provides a bit of buoyancy to make sure that the brain is not just going to keep constantly hitting the cranial vault or anything like that. And obviously, you don't want the brain to be fixed by like fibrous tissues or muscles or anything, because then that's going to prevent its movement. So you want something that's fluid, and that's what CSF does. But of course, we don't want too much CSF to be present because that'll obstruct parts of the brain or cause compression of the brain. And we don't want too little because then it'll dry out, less nutrients as well as less buoyancy. So we want a system that's able to kind of keep it within an ideal volume. And that is what the ventricular system does. Now, where does the CSF start from? Well, the ventricular system as a whole is lined by ependymal cells, which contain the choroidal plexus. So remember the vessels that supply this choroidal plexus? It's to be able to support the plexus's function, which is to produce that CSF. Where does it go from there? Well, it starts off firstly within the lateral ventricles, and you can see in the bottom diagram here, you've got these two lateral ventricles. If you look at it from this angle, it kind of looks like, I don't know, the way that I imagined this was that it looked like a goat or a ram with the eyes in the middle. It's kind of a funny looking thing. Just remember that the ventricular system is not actually a structure like this. Like it's actually like a hollow space essentially. So this is more kind of like if you were to inject dye into it, or if you were to inject like plaster or something and then take it out, that's the shape that it would take. So you've got those lateral ventricles on either side. So those are essentially the first and the second ventricle. And the lateral ventricles are located within the hemispheres of the cerebellum. So the easiest one to remember, where they are. And they give off horns that project into the frontal, occipital, and temporal lobes. So you've got this anterior horn, which is going into the frontal lobe. You've got your posterior horn, which is going into the occipital. And then you've got this horn here, I guess you could say the lateral horn, or the inferior horn that goes into the temporal lobe. And it's the main site that CSF is initially made. CSF is made through the whole system, but because these are the larger ventricles, that's where they're made first. And both of the sides, the first and the second ventricles, they're going to be separated in the middle by this thing called the septum pellucidum, which is this structure here. Then these will drain into the third ventricle. So these are going to be situated between the left and the right thalamus. They're connected to the lateral ventricles by this thing called the interventricular foramen of Monro, which is not really actually that visible here, but it's supposed to be this kind of, maybe it is, no, it's not really. It's supposed to be this sort of thing here that is supposed to be connecting both of those ventricles together. I guess it's also here. Yeah, that's probably a better one. That's the interventricular foramen that connects the lateral and third ventricles. It also anteriorly projects into these horns as well, I guess you could call them, the supraoptic and infundibular recesses, but you don't need to know anything about those ones per se. And then eventually the third ventricles drain into the fourth ventricle, the last one, which is within the brainstem between the pons and the cerebellum. So you can see that here, right, between the pons and the cerebellum, you can see this dilation, which is the fourth ventricle. Remember, it's just a space, and it connects to the third ventricle through the cerebral aqueduct, which is over here, represented by this space or this passage here. But in this diagram, you can see it very nicely as that, right? You can see over there. Yeah, so it's connected through the aqueduct. It supplies the central spinal canal, so the fluid enters and bathes the spinal cord, and it also goes into the subarachnoid space, which is going to bathe the brain. So it's going upwards, and it's going to be reabsorbed within the arachnoid villi. So you can see here, you've got two passageways, one for it to go down into the spinal cord, and one for it to travel back around behind the cerebellum, up into the cerebrum again, and then you can see how it gets drained into the arachnoid villi, into the granulations, and it basically re-enters back into the venous sinuses, where it then goes back to the arachnoid granulations, and back to the choroidal plexus, where it then produces the CSF again. So you have like this recycling process happening. What's important to remember here is that the apertures by which fluid exits out from the fourth ventricle and enters into either the spinal cord or the CNS brain aspect. So you've got the medial aperture, which is going to be not really well shown here. I guess it's labeled here, but it's difficult to see. That's just going to be kind of in the middle. That's the foramen of Magendie. And then you've got lateral ventricles on either, lateral apertures on either side, which you can see one of here, which is known as the foramina of Luschka. So if you have blockages of either of these, you end up with a condition called obstructive hydrocephalus, where you have an obstruction, stops drainage, and therefore you have hydrocephalus, which is too much CSF building up in the CNS. But again, you don't need to know the clinical pathology of these yet. So again, I'm just going to quickly go into looking at a 3D diagram of this before we come back here again to finish off on some of the clinical syndromes. All right, so here we've got our beautiful ventricular system. Again, remember that the ventricular system is not really like this. This is more of like if you were to put some plaster in and take it out, but this represents that negative space where you have the CSF actually building up. All of this is lined by those ependymal cells, which are producing the CSF. The biggest question that I wanted to answer here is a lot of people wonder why you have this hole in the middle. And that's really because if you bring in some of the actual brain tissue, you can see that it's surrounded by, or you can see that the third ventricle specifically is going to be flanked on either side by the thalamus. So then you have these interthalamic, which is kind of hidden here, but you have interthalamic extensions that have to connect between the two thalami, which is why you end up with that hole in the middle. But other than that, you can kind of see how the drainage works, right? You've got first ventricle or the second ventricle, the lateral ventricles coming in, going in down here into the interventricular foramen of Monroe, going into the third ventricle. The third ventricle then drains down here into the cerebral aqueduct, down into the fourth ventricles, which is you've got the pons and you've got the cerebellum on the posterior side. And you've got these apertures, which are actually much nicer to see here. You can see the median aperture, which would be down here. And you've got these lateral apertures on either side, which are going to be how the CSF exits out and drains into the CNS. And then they will eventually go through those arachnoid granulations back into the venous sinuses and then drain back and produce CSF. So nice recycling process. All right, and I guess the most important thing to understand out of this entire talk is going to be if you have a stroke in a particular artery, what symptoms would you expect in a patient? And these are the way that questions are going to be formulated in your exams. So you've got a patient with this symptoms, which artery is most likely to be affected? So as a general rule, if you are stuck, remember that the MCA, the middle cerebral artery, is the one that's most commonly going to be affected because it's directly coming off of the ICA. In fact, remember the ICA just continues as the MCA. And just as kind of backtracking a little bit, remember that strokes, there's two common causes. You have these embolic strokes, which are essentially going to be when something gets flicked off an artery and it goes up into the brain. So for example, you have someone with atrial fibrillation, a clot develops within the heart, and then it goes up into the brain and causes a stroke. And less commonly, you have hemorrhagic strokes, which are, due to atherosclerosis or hypertension, where you get bleeding into the brain. But about 80 to 90% of strokes are because of embolisms. So we're going to talk about those more right now. So MCA is most affected, but you need to know how each of these would present just in case they come up in an exam. So I've got the diagrams here just to help us as well. If you have an ACA stroke, remember that it's going to be the anteromedial aspects of the brain. So it makes sense that it's going to be affecting the lower limbs. So you get loss of motion and sensation in the lower limbs. And remember, because those fibers decussate before they reach the brain, you're going to have those losses being felt contralaterally. So if I have a right ACA problem, my left leg is going to be the one that suffers the most damage. Okay. Same with the MCA, but instead now we're going to be focusing more on the lateral aspects, so face and upper limbs on the contralateral side. Note, however, that remember you've got MCA's segments, right? And if you have something affecting like the M1 segment, which is like the most proximal, it's going to be affecting those lenticular striate arteries that supply the internal capsule. And if it affects the internal capsule, then you're actually going to end up with something that's a bit more extreme, and we'll cover that in just a second. If you've got a dominant stroke or an infarct on the dominant aspect of the brain, so the dominant lobe is what I'm trying to say, you will end up with an aphasia because you're going to be stroking at Broca's and Wernicke's region, which are most commonly on the side of the dominant cerebrum. And if it's on the non-dominant side, it's not like you're going to get away scot-free. You'll still have a contralateral hemi-neglect syndrome, which is essentially where if I have stroked out my left middle cerebral artery on the non-dominant side, for example, then I won't be able to appreciate things that are on my right-hand side. So you might have patients who forget to button up the cuffs on their right-hand side, or they'll, when they're driving, they don't even realize that there is a right-hand side, or they'll forget to brush their hair on the right-hand side. They'll just kind of neglect that whole part of their body, which is unfortunate. And if you have damage to the visual tracts, because remember that these optic tracts actually also travel along the lateral aspects of the brain. If you have damage to those, which can or cannot happen, you will have contralateral homonymous hemianopia as well. So some vision problems too. With the PCA, remember that it's the occipital lobe. So you're expecting that it's going to be contralateral homonymous hemianopia, but you will have macular sparing because the MCA is going to help out. It actually has some collateral supply to that occipital aspect of the brain, which has the macular, or the part that interprets the macular aspect of your vision. You'll also have issues with the thalamus, because remember, PCA supplies a lot of like thalamus, hippocampus, that kind of thing. So you can have hemisensory loss, because it supplies the part of the thalamus that is having all these sensory fibers coming through it. And finally, you've got lacuna infarcts, which is just a fancy way of saying infarcts to some of these really small arteries. So small, but because they're the small arteries, they supply the deep white matter structures. So those lenticular striate arteries we talked about and other things. The most high yield example, there's so many, but I don't think it's worth knowing every single one. The high yield example is going to be the capsular strokes. So if you stroke out the whole capsule, the internal capsule, then you end up with one-sided motor deficits. So not just the upper limb or not just the lower limb, you'll actually affect everything. So face, upper limb, lower limb. So that's the most important thing to know. Now, the other sort of syndromes like the lateral medullary, anterior medullary, like Wallenberg's and that kind of thing, I don't think it's actually that important for you to know at this stage. You might cover it once in a lecture, and maybe there'll be like a question in a practice exam that covers the medullary syndromes, but I don't think it's actually that important to know the details of that particular pathology. What I think is most important is going to be this topic on the major strokes in the cerebrum, as well as the bleeding that you can get, which we covered in a previous lecture on the brain and spinal cord. So that covers everything that you need to know for the blood supply and ventricular system. I hope that the 3D models helped you, and if it did, please let us know, and we'll try and include those more in our anatomy lectures. I would recommend also just doing some of this on your own, so that you're able to visualize it come exam day, and there's a question about neighboring structures and how that would impact on the blood supply. Keep looking at my notes if that's been helping you, and of course send me messages if there's any issues. I hope that was okay, and I'll see you in a future lecture. See ya.